So at this time, we're going to open our panel. And so all of our speakers should have their cameras on and their microphones on. And I have a lot of questions that have come forward. So I will start going through those, and we'll do our very best to get through all of them and give everybody a chance to, or most of you a chance to respond to multiple questions. So what I'd like to do is start with Arij and Stacy. So I'm going to start with the sort of adult and pediatric perspective to this question, if you both could weigh in. This question came from the folks from the Social Security Administration. And the question is as follows. What would be an average weekly or monthly time commitment for someone post-transplant, immediately after transplant, and then maybe a year post-transplant? What is the commitment to the interventions that are really critical to their recovery? Arij, do you want to start?
Thank you, Margaret. Thank you for that very thoughtful question. I should say that for the purposes of the intervention studies that I summarized, there's a lot of randomized studies that have been done specifically focusing on that acute period immediately post-transplant. And they have shown a very consistent pattern that the intensity of the intervention matters, that higher intensity intervention improves outcomes more. There is a clear dose response curve to the intensity of intervention. And I would say the second piece is supervision matters. So providing our patients with the capacity to work with a therapist, for example, a physical therapist, to come up with an exercise program is better than giving them a video or giving them a program that is self-administered to help with their exercise. So early post-transplant, so that's the data. These are the data from prior intervention studies. I'd say for the majority of our patients, the maximum we can get from physical therapy is about 2 sessions a week post-transplant, especially for patients who are frail and deconditioned. And often we can get that for a couple of months. And for patients who are frail, that is just not sufficient, I will tell you. The other piece of this is the difficulty in getting patients to receive home physical therapy and home occupational therapy acutely post-transplant. We discourage these patients actively from seeking outpatient appointments. And so the hope is with the availability of telehealth and the access to physical therapy through telehealth, that may actually increase our access and scalability, but it is even challenging to get physical therapy covered twice a week at home for most of our patients. But I'd say early post-transplant, that's the frequency that you're shooting for, both from a clinician perspective as well as from just knowing what we know about the data. In the post-transplant, the 1 year it's really tailored to the needs of the particular patient. And it depends a little bit on their complications related to transplant, whether they've had graft versus host disease, or they're on chronic steroids. But again, even while we have limited data, even in that context, we know that intensity and supervision matters, and having a program that is comprehensive, that's tailored to the needs of patients, is really important.
Thank you, Arij. Stacy, from the pediatric perspective.
Sure, and I completely agree with what Arij highlighted. I think to give sort of a nuance about the pediatric and transplant, or excuse me, an adult component in that first year post-transplant, I think is largely a distinction as well, in that an increasing number of adult transplants are actually occurring in the outpatient setting, where that is something that we do not do in the pediatric setting. And I think that skews the time commitment greatly, because that means the majority of the initial care in that first year is either in the hospital or immediately adjacent to the hospital, requiring living facilities close to the hospital for frequent transplant visits, where some of those services are provided in the clinic or at the hospital-based clinic itself. And so that the bulk of the data and research says that first year post-transplant is the most time intensive, as well. And again, that is conditional upon the intensity of the treatment. But as you go out further from transplant, assuming, we are reaching the outcomes that we expect, that time lessens. However, as Arisa alluded to, that depends on the complications and complexity of the patients themselves, and in fact can vary from requiring an inpatient rehabilitation facility to home therapy as needed.
Thank you, Stacy. What I'd like to do is just shift to both Suzanne and Margaret, our caregiver, for just a second. We've talked a bit about how important rehabilitation services can be in recovery. And we've also heard a little bit about palliative care and sort of symptom management and how important that can be during recovery. And Suzanne, I thought, could you take a minute to maybe speak about your experience with either of those services, and then maybe Margaret, your experience from Jackson's perspective and how those services might have been part of his care?
Sure. After my transplant, I did not have any home care visits, or I really wasn't offered any of those options or any rehabilitation or physical therapy. I made myself go out and take walks and get together with friends, but there was nothing formal about it. Since then, because of some of the side effects of the transplant, I took a horrible fall and broke some bones. And then I was offered in-home occupational and physical therapy. And what a difference that made in my recovery, much faster, not having to go in, especially during COVID, go into a gym or an office. That made just a world of difference. So I think that everybody should try to get that in after the transplant. I wish I had had that opportunity.
Thank you. Thank you, Suzanne. Margaret, did Jackson use any of those services, either from rehabilitation, physical therapy, or palliative care to manage symptoms and recovery?
Yes, he used physical therapy for the first 100 days post-transplant. I think it was very good for him being, a 17-year-old male, especially that he was able to physically go and do this. And that was something I kind of let him do kind of on his own. I wasn't there with a therapist, and he improved greatly with that. So I think this was very appreciative, and he had very good results in his muscular strength doing that.
Excellent. Thank you for sharing. Stacy, we have a specific question for you. If you could elaborate a little bit on the Medicaid findings that you mentioned. Low-income transplant children, of course, will overwhelmingly be on SSI or Medicaid. And is the issue that you were discussing simply Medicaid's association with poverty, or an actual quality of care matter, or a bit of both?
Well, I guess my first response is that it can't be simple. When we talk about social determinants of health, all of those aspects are interconnected. And so it's very difficult to tease out one particular aspect. You're certainly correct in that poverty and Medicaid often are linked because the requirements for inclusion in Medicaid are often income-based. However, there are some disability requirements that or eligibility factors that people meet that do not have the income requirement. And as a result, again, it makes it somewhat unclear if it's purely poverty that is the risk factor, or if it's these other factors in terms of access to care, in terms of simple things in terms of transportation or health literacy or other variables. So I don't think the data we have to date can clearly say that. But as I alluded to, our efforts are in part to better explore that so we can better describe what the key factors are. But certainly, I think addressing access to care and accessing resources so that patients can and families can have all of the services they need to reach better health will be a key aspect or intervention in terms of improving healthcare outcomes.
Thank you, Stacey. And while we're in that space of sort of the financial challenges, Suzanne, I have a comment directed to you from Dr. Fred Applebaum. And he wanted to thank you for your comments and ask what, if anything, was useful in helping you navigate the difficult financial jungle of reimbursement. You've obviously given this a lot of thought, and we wondered if you have ideas of what might be done to make it easier. Suzanne, if you could respond, thank you. You may need to turn your come off mute, Suzanne.
You know, I thought I was pretty good at researching and navigating until I hit the healthcare system. And I still spend hours on hold and on my phone trying to get through to a real person. And I have really good health insurance from CBS News retiree plan, but getting through and then having them contact the doctor for the right code, it's just a web of confusion. And even if you get somebody really helpful after waiting 45 minutes, I very seldom hang up having my issues solved. And it always amuses me when they put you on hold, they say, please wait, your call is very important to us. And then I wait for 45 minutes and I'm thinking, well, it's not really that important. But I don't feel like I have any good tips that have worked for me. I do email, I go on their Facebook page, I call, and I still don't feel very effective. So lousy answer, but that's the truth.
Well, sometimes reality is what we need to hear. So that's really helpful, Suzanne. Margaret, can you speak to this from your son's perspective? And I assume you were navigating the sort of insurances and financial challenges on behalf of him. Were there any tips that you want to share that really helped you navigate this with some success?
It was a little bit different for Jackson and myself and our family because we were based in Canada afterwards. So a lot of it was covered by our provincial health insurance plans, and we couldn't feel luckier. Mm-hmm.
Very different systems. That's right. Thank you. Do any of our clinicians have anything to share related to this issue before we move on?
I will just say, one of the key aspects, as Suzanne alluded to, is it's just really a difficult process to navigate, to know who to talk to, who to get in touch with, and also what resources are available. And often there are a lot of resources, it's about accessing them. So there is a growing body of literature on patient navigation to address financial toxicity and financial distress related to transplant, as well as in the context of cancer care in general, or complex health conditions. And so I suspect that Dr. Arnold actually can talk about that more than I can. But I do think that there is growing evidence that navigators can really help, navigators who are empowered with the right information, who are able to navigate the healthcare system, can play an important role in helping our patients and their families navigate the complexity of our healthcare system.
You're exactly right, and actually took the words right out of my mouth. I think what we are learning is that the more preemptive we can be in not only assessing potential financial hardship, but also helping patients and families navigate it, the better experience can be. And whether that's a patient navigator or a financial counselor or both in tandem, our experience is incorporating those individuals before transplant and then continuing through transplant certainly has improved the experience. Ultimately, we have yet to reach the perfect state that I think all of us would like to see, but that's certainly a potential step in the right direction because it not only gives you access to someone who's well versed in that landscape. Many of us don't speak ICD-10 code or all the other things the insurance companies want you to know. But they also are aware of the different resources available to patients and families, whether that's Social Security, whether that's FMLA, or even foundation resources, National Marrow Donor Program resources that many patients and families are not aware of.
Thank you for sharing that, Stacy. Karen, I have a question for you, if you would. You spoke a lot about patient-reported outcomes, actually across from the very first speaker or this morning all the way through our session. We have been hearing from everyone about how important it is to collect the patient's perspective on their recovery or their experience. And so I just wanted to ask, because we talk a lot about the research, but how does the information from these questionnaires that we collect from our patients and from our caregivers actually inform the clinical care that our patients are receiving?
Thanks, Margaret. That's a very good question. And I think over time, we've come to really appreciate the value, the importance of the patient voice. And Dr. Arnold talked a little bit about that patient-centered study that Linda Burns led, where we really listened to the patient voice. I think that we increasingly understand that without the patient perspective, our interventions have a far more limited chance of being successful. If we're not hearing what's the priority of the patient, what are the problems the patient's facing, we really can't provide the best either medical care or overall, whether it's rehabilitation or clinical care in general. So I think that without a patient perspective and knowing what that patient is facing, we're not going to be able to optimize our care. A quick example of financial toxicity: if a patient has to choose between a medication and a meal, obviously whatever we prescribe is not going to be effective, as effective with that person if they're having to choose meals for their family over medication for one patient. So that's just a quick example, but I think it reflects the importance of understanding the context that we're treating, not just the medical biology.
That's great. Thank you, Karen, for sharing that. And really, it's a beautiful transition into the next series of questions, which are really directed, Suzanne, to you, and Margaret, to you. So to the patient and caregiver, because the audience is very interested in hearing more from you about your experience. So I'm going to start with MJ. So as a caregiver, did you find there were topics or areas where you struggled to get an accurate picture of what your patient or your son was going through and what the limitations might be?
Yes. We didn't speak about identity and appearance very much prior to transplant. My son Jackson is very proud of his, or is very concerned about his appearance, both physically, and hair loss was extremely difficult for him. And so many people would say, oh, just throw on a baseball cap. Oh, just do this, do that. Oh, it's going to grow back. It hasn't grown back, to where it was prior to the transplant. This has been a very significant mental dilemma for him to recover from. We're coming up to 5 years after his transplant, and him and I just went to see a specialist, and he will be probably, he is a good candidate for a hair transplant, and he will be receiving that hopefully in the next year. But to carry on feeling, I don't know how to put this, but it was very significant to him, his appearance. So, after 4 years, we've finally addressed this. We were addressing it throughout his recovery with products to increase his hair growth, both naturally and with pharmaceuticals, but nothing has seemed to help him to the point where he feels most confident.
Thank you for sharing. And in the 3 decades that I've been involved, or almost 3 decades in transplant, that's one thing I've actually learned today, because I haven't heard of individuals really approaching their hair loss in such a unique way. So thank you for sharing that piece. Suzanne, a question that came through, interested in the patient's perspective. Can you speak to any hesitations that one might have when deciding to undergo a transplant, a stem cell transplant, or reasons that a patient may choose not to move forward? Sort of, what were some of the issues that you had to weigh one way or the other when you were making the decision to get a hematopoietic stem cell transplant?
Well, that's a good question. I initially, my doctor, I think, was so concerned that I know everything going in that he told me every single worst case scenario. And I really thought I wouldn't go through it because, they bring you to the brink of death and then they save you at the last minute with new cells. And and all the horrible things that could happen, not to mention, you could die right then. And when I started all this, I had 3 kids at home. Well, 2 kids at home. My oldest daughter had gone to college. So the idea of leaving my 3 kids so soon because of a transplant. And then there was one nurse during an infusion who said her father had decided not to get a transplant. And then at the last minute changed his mind and it was too late. And she knew he could have gotten through it. And she said, just from spending all the, when you're with a nurse during weekly infusions or biweekly, you get to know each other pretty well. And she said, I know you'll be able to get through it. And I don't know, that was kind of, her story just hit me that I should at least try. And I do understand telling the patient the worst case scenarios so you're not surprised. But my doctor afterwards said, do you think I laid it on too thick? And I said, yeah, because you didn't really tell me any good.
So I think, Karen, can you hear me? Because I'm seeing that it looks like Suzanne is frozen. Is she frozen?
Yes, she is.
Okay.
Yeah.
Okay.
Suzanne,
Okay. So Suzanne, while she's unfreezing, I think we got a good bit of information from her. And we're actually almost to the end of our time. So I do have one last question. And Margaret, I'm going to send it to you as a caregiver. And that question reads as follows. So when you were supported by the transplant team and nurses or other experts, like beyond physical activity during the transition from inpatient to outpatient, and this of course is referring to your son, were there other things such as medication adherence or symptom management and self-care management, things of that sort, that were really important interventions that made a difference for him and his compliance, for example, in his plan for recovery?
Can you kind of expand on that a bit, Margaret? Sorry.
No, of course. I think what the ultimate question, I think, is, sometimes there's the compliance issues, there's the subtleties, the symptom management that are really complicated parts of recovery. And were there issues like that ever talked about, or was that sort of your motherly love coming in and making sure your son did what he was supposed to do?
You hit it right on the head there. It was more a motherly love. We were we were attached 24/7. So I think it was a bit, easier for Jackson in that sense that I was there with him 24/7 for about a year.
Making sure he was taking his medicine and that he was having his symptoms managed. Those are some subtleties that, you get a prescription, it has instructions on it. You might get a piece of paper that gives you a little information, but there's a lot of layers of detail that one has to understand and how to actually implement all those things in a way that actually allows the patient to have the best outcome. And it sounds like you learned to be a great nurse while you were caring for your son. Well, I believe we are at our time. Are there any closing remarks that anyone wants to share before we close the session? Well, I would just like to say it's been an absolute honor to be here today amongst all of you, and not only great peers who have been researching some of these very important issues for a very long time and providing such amazing care to their patients every single day. But I think I speak for all of us, Suzanne, to you and to Margaret, for coming today to share your stories, some of the more intimate details, frustrations, and successes that really do shine a light on the work that we do every day and inspires us to continue to do it with all of our heart to help both you and patients in the future to reach their fullest potential in recovery. So with that, we'll close the session and hope everyone has a great day.
Thank you.